Think forward. Think Research Channel.
Thank you, Nora. I'd like to thank you in particular for asking me back. I really enjoy speaking in this forum. I want to thank all of you for coming tonight, and the topic for tonight is going to be something near and dear to my heart, modern rhinoplasty surgery, which involves both aesthetic and functional surgery of the nose. And before I go on, I thought I'd just take a minute to talk a little bit about the Division of Facial Plastic Surgery here at Stanford. We provide reconstructive and aesthetic services to patients. Reconstructive services are both adult and pediatric and include trauma reconstruction, cancer reconstruction, congenital anomaly reconstruction, and aesthetic surgery of the face, a full range of different types of surgery, including aging face surgery, which is one of the major subdivisions, and non-aging face surgery. And you'll notice that we have lit up in two different places here rhinoplasty. And that's because rhinoplasty can be considered a reconstructive procedure in many senses, as we're reconstructing the nasal airway. It can also be thought of as an aesthetic procedure, and probably that's the way most of you think about it. And one of the things I'm charged with tonight is to convince you that modern rhinoplasty is more than just about changing the shape of the nose from the outside. So in getting ready for this, I looked up the definition of rhinoplasty online. I don't think there are any hard copies of dictionaries anymore, so I looked at the Merriam-Webster online dictionary. And in addition to making sure I was pronouncing it correctly, I found that this term came up in 1842, which is interesting to me because I thought the first rhinoplasty was done in the 1870s, and that it was essentially defined as plastic surgery on the nose for cosmetic purposes. And this is the classic nose job. And this is what most people think of when they think of rhinoplasty surgery. But I would submit to you, and I hope that by the end of this evening, you understand that rhinoplasty surgery is really about more than that. And it's about both functional and aesthetic changes to the nose. And they both go hand in hand. And you really can't consider one without the other. The goals of rhinoplasty are really the goals of any surgical procedure. First and foremost, you want to do a safe procedure. In terms of the aesthetics of the nose when it's done, you want it to have a really natural appearance, whether you're doing functional or aesthetic surgery. You want to maintain or restore facial harmony and balance, and we'll talk a little bit about facial aesthetics in the second portion of this talk. And maintenance or restoration of nasal function is of paramount importance when you're doing this type of surgery. So our goals for tonight. First and foremost, I'd like you to understand some basic anatomy of the nose, at least as it pertains to the type of surgery we're going to be talking about and structural support of the nose. Understand major anatomic causes of airway collapse and obstruction. Understand the term functional rhinoplasty, and understand issues in treatment of nasal obstruction. And finally, some issues in aesthetic rhinoplasty that we'll be talking about towards the end of the evening. This is actually a concept that I discuss with the residents and doctors in training, and that is the appearance of the nose is the result of a complex relationship between an external envelope and a bony cartilaginous skeleton which lies underneath. And this can be thought of as the tent. This is the so-called tent concept of the nose. The bony cartilaginous structure would be analogous to the poles that you put up for your tent. And the external lining is this tarp that you put over that. And it's the interaction between these two that results in the ultimate appearance of the nose. And it's the structural support underneath that gives it its strength that resists collapse and allows you to breathe and results in the nasal airway. And these are the things that we operate on. When you look at the basic nasal anatomy, I'm not going to go through this in detail, it's not really necessary. The major points here are that the nasal bones sit up here at the top of the bridge, And the rest of the lower 2/3 of the nose is actually all cartilage. And if you see a skeleton, you know that. There's nothing there but sort of a small hole. The cartilages are paired up above. There's a septum running down the middle and paired cartilages down below. And importantly, out here in the side of your nose, there is no cartilage. There's nothing there. It's just fibrofatty muscular tissue, which is very firm, and this supports your lateral nasal airway with its connections to the piriform aperture, which is this bone out here on the skull. If you look at this in cross-section, it kind of makes a little more sense. This is an image taken from our chapter we're writing on functional rhinoplasty for an upcoming textbook. And if you look at cross-sections through the nose, as shown here in A, B, and C, you can see how this nasal airway is supported by cartilage and bone all the way around. And as you come down further down here, there actually isn't any cartilage out here laterally. There's just this fibrofatty tissue complex, which can lose its stiffness with age and time or due to trauma. So why do we have this shape to our nose? There aren't too many other creatures walking around or crawling around with a similar structure. The reason is probably related to evolution, and the anthropologists feel that it's probably due to Homo erectus moving from humid environments to more arid environments, and this nasal structure was required to maintain humidification of the air that we breathe through our nose. So this nasal function that we talk about is actually more complicated than simply nasal breathing. Being able to move air through your nose is important in your ability to voice properly, so communication. Of course, moving air through the nose is important for olfaction or smell. When you breathe, you actually modify the temperature of the air before it reaches your lungs, so it has an important physiologic function. It also humidifies the air and retains water as you breathe out through your nose, so it's a water retaining mechanism, and this is related to that evolutionary idea that I mentioned earlier. And you filter some particles through your nose, which is a little gross to think about, but it actually has that function as well. But when I talk about nasal function in functional rhinoplasty surgery, I'm not talking about correction for any of these other things. I'm actually talking about the main function, which is just simply the movement of air through the nose. And changes in the ability to move air through the nose can have a significant impact in your quality of life. And this is something that we've studied. It wouldn't be a lecture without some physics, so we'll just mention a little bit of physics. Poiseuille's law essentially is listed here. We don't need to go into the details. The main issue that I'd like to point out is that very small changes in the radius have massive changes in the ability to move air through the nose to the 4th power. So the radius to the 4th power makes a difference, is inversely related to resistance and directly related to flow rate. And so if we have very small changes in the lining of the nose or obstruction of the nose, we can have massive changes in the ability to move air through the nose. And keeping this in mind, there are two major categories of nasal obstruction that I like to think about. These are the variable structures and the fixed structures of the nose. The variable structures are essentially related to the lining of the nose. So we talked about the bone and the cartilage that's inside the nose. There's actually a lining of mucosa, which is outlined here. I drew it here in red. And this is, by the way, a cross-section through the nose. So this is the nasal bridge. This is the bottom, as if you're looking up someone's nose and they're laying flat. And this is the septum here and the lateral sidewall here. This lining here, when we get a cold or we have allergies, becomes thickened. And very small changes, as I mentioned, in that radius can make a big difference in your ability to breathe through the nose. With allergies and other things, this thickness can vary, and so this is a variable structure. So when we talk to patients, we ask them about their history of allergy disease, allergic or non-allergic rhinitis, sinus disease. We look in the nose, we see if there's evidence of swelling or other telltale signs of allergic disease. And the other major category of nasal obstruction would be fixed obstructions. These are things that don't change. Fixed structures include the septum, the upper lateral cartilage, this angle up here. We call this angle up here the internal valve area, which we'll be talking about more in a little bit. The size of this turbinate bone, which doesn't change. All the things underneath that mucosa. And when we talk to patients, we ask about a history of trauma. Sometimes there's no history of trauma. Things can just be bent out of shape anyway. The laterality of symptoms, whether one side is constantly obstructed and doesn't change, that's a sign that it's not something that's variable. And we look inside the nose at the septum, these turbinates, which are these things on the sides here, and the internal and external valve, which I'll explain a little bit more in just a bit. Now, this sort of dichotomy of variable structures and fixed structures provides also a management mechanism. And basically, when there are problems with the variable structures, the mucosa in other words, we generally treat folks with medical therapy. And that's usually our first line anyway. We don't want to go straight to the knife. And nasal steroid sprays, which are now quite common and quite safe, even in pediatric populations, can have a really nice effect in terms of reducing the swelling of that mucosa. Antihistamine therapy, which is now largely over the counter, and ultimately, if allergies are an issue, immunotherapy. The second line, of course, would then be treatment of the fixed structures. Folks who have failed medical treatment or have strong evidence for a fixed obstruction are not going to respond to medicines very well. And in this case, there may be a surgical procedure which can be done to alter the structure of the nose such that airflow is improved. And this is septoplasty or other types of functional rhinoplasty maneuvers. And, you know, functional rhinoplasty is in and of itself a large topic, but I thought I'd break it down into a few different areas based on the anatomy. And we talked about some of those fixed structures, and the first one is the septum. We've probably all heard of people having a septoplasty or septal surgery or a septal deviation, and let's talk about that first. If we take a cross-section sideways through the skull, and this is a cartoon diagram of that, this is what the septum may look like. So this is the dorsum of the nose, the bridge of the nose up here, and the nostril where we breathe in air is right down here. And this cutaway section of the skull shows where the septum would be, which is primarily cartilage in this front portion here, and has bones in back which are thin, but all of this supports the structure of the nose. In a septal deviation, this septum will be coming out of the page or out of the screen or away from the screen and blocking the nasal airway on one or both sides. Septal deviations in and of themselves are not uncommon. So if we took 100 people off the street, we may find septal deviations in many of them. But a septal deviation that causes nasal obstruction and correlates with a nasal obstruction is an indication perhaps to have a surgery, not just a septal deviation in and of itself. When we do septal surgery, we can actually remove some of that bone and cartilage safely without any change in the structure of the nose, as long as we preserve a strut of bone and cartilage that supports this part out here externally. Sometimes we can actually do some things to the cartilage up in the front here to manipulate it, to make it go in or out or make it straighter. But by and large, most septoplasty surgery, which is an outpatient surgery, involves something like this. And so what is a septoplasty? It's an outpatient surgery with incisions only on the inside of the nose. And in this case, we remove or manipulate the septal cartilage or bone to get it straighter and improve that nasal airway. There are no intended changes in the external nasal appearance. I can't tell you how many times I have folks who come to me who say they've had a septoplasty and nothing else done, but of course they've really had a rhinoplasty. I think that was more commonly done in the 70s and 80s and not so much anymore, but that is often the case. But there are some times when the septum is so deviated that there's an obvious external deformity. And this is an example of one of my patients who had a very severe septal deviation due to trauma as a child, and the septum grew in the wrong direction. In this case, you can see that there's flattening of the nose in the central area, and on the side view, there's what we call a saddle here, because the septum is about 80 or 90 degrees away from the direction it's supposed to be going. It's literally blocking both sides of her nose. She's not so concerned about the external appearance, although she wouldn't mind it being better. She really just wants to be able to breathe. She has essentially no nasal airway on the left side and a partial on the right. And this is just sort of a close-up view showing that this red line is where that septum's going. Where the bones are, it's straight, but when it comes out to the cartilaginous portion, it's waving all the way off towards the right and then back towards the midline. This is a challenge that a standard septoplasty wouldn't be able to address. As I mentioned earlier, we preserve generally the strut of cartilage and bone across here in order to support that nose, but hers is twisted up here in the front. So how do we go about fixing that? And I published a paper describing a technique where we actually remove this entire cartilage and take a straight portion of it and reconstruct the nose by placing a part of it back in there. Now this is not done with a standard septoplasty approach. It's done with more of a functional rhinoplasty approach, so it doesn't count as a regular septoplasty. But with this, we can actually correct very severe deviations of the septum. This is more of a cartoon diagram demonstrating this, where we keep this dorsal strut, which means up top here, of cartilage, and replace a portion of the cartilage down below with a piece from in back that's straight, and support the nasal tip and preserve the nasal form, and also improve the nasal airway at the same time. This is the only bloody photo I'll be showing, but this shows this septum coming out here. The skin's been retracted on the nose, and this shows a severe deviation of the septum. It doesn't look as severe once we get it out here, but this is out on the operating table. And then by placing it back in, that wasn't the same patient, by the way, we actually do get some change in the aesthetic appearance of the nose, which is not the intention of this surgery, but just by replacing that cartilage in the appropriate position, we do get that. And you know, she's actually somewhat straighter under her frontal view. This is about a year after surgery, not perfectly straight, which brings up a good point about crooked nose surgery. We'll be talking about that specifically later, but in cases of severe deviations, it's really not likely that things are going to be perfectly straight afterwards, and I make that pretty clear to my patients. But she actually did very well. Most importantly, she could breathe very well. But what about the turbinates? If you peel back that septum that I had in the other diagram, you'd look at the side wall of the nose and you'd see turbinates. There are 3 pairs of turbinates in your nose: inferior, middle, and superior turbinates. And the inferior turbinate is the one that we're going to be talking about, and it's the one that can essentially block your nasal airway by being swollen. If you catch a cold, it almost completely obstructs your nasal airway just due to swelling. It's composed of a very vascular lining, so that changes with time, and a bone on the inside which doesn't change shape. In cases where with nasal steroids there's still so much tissue there that it's blocking, or the bone is enlarged, we can actually do a surgical procedure to reduce that septum, turbinate, such that you actually have a better nasal airway. Initial management, as I mentioned, is nasal steroid therapy or allergy management. But failing that, there are a number of different modalities that can be used to reduce turbinate size. One which you may have heard about is radiofrequency ablation of the turbinate. And with this, it's an office procedure where essentially a probe is placed into the turbinate with local anesthesia, and radiofrequency energy is applied to it, and scarring and shrinkage of that turbinate occurs. Usually 2 or 3 sessions are required. Failing that, more invasive surgical procedures can be performed where we actually go in and remove tissue. Microdebridement involves placing a device called a microdebrider that actually removes soft tissue from the area. We can actually just sort of break them, push them out a little bit, which is probably the least effective of these. It's often done in combination with other things. Or a mucosa-sparing resection where we actually make an incision with a knife, go underneath and remove some of that bone such that there's less projection of that turbinate into the nasal airway. Just a quick point about turbinate resection. In the past, complete removal of the turbinates was advocated. As I mentioned earlier, humidification of the air is one of the important functions of the nose, as well as filtration. And it's possible to over-resect the nose. So mucosal sparing turbinate surgery is really the way to go in modern nasal surgery. Now we moved on to talking about traditional functional, now more modern functional rhinoplasty procedures. And what I've talked about so far is more just septoplasty and turbinate reduction, notwithstanding the anterior septal reconstruction procedure. I've alluded to the internal valve and the external valve. Let's talk a little bit more about that. First, word about functional rhinoplasty, and if it seems like I'm talking about this a lot, it's because I really want to get the message across about the functional nature of some nasal surgery that we do. We use a similar approach to what we do for cosmetic rhinoplasty. We lift the skin of the nose and look at the bony cartilaginous skeleton. But our goal when we manipulate that skeleton isn't just to take down a bump or do this or that. It's actually to improve nasal breathing and not aesthetics. We want to strengthen, and in some cases widen, the nasal skeleton so folks can move more air through their nose. And any changes in the external appearance of the nose are not done solely for that purpose, the purpose of changing the shape. They're done for expanding the nasal airway. In some cases, the nose may look straighter, as I showed you earlier, but it's certainly not the primary intention of the surgery. It can be done at the same time as aesthetic surgery, but in the cases of pure functional surgery, it's not. Now, the internal valve was described back in the 60s or 70s, and someone had the idea of looking up into the nose and noticed that there's this angle here. This is looking up someone's nostril. I hope they're asleep because that doesn't look very comfortable. But the angle here between the septum and this upper lateral cartilage, and thought that, well, the normal should be 10 to 15 degrees, and if it's narrower than that, then they've got an airway problem. Well, I've yet to see a protractor that'll fit up into someone's nose and measure, and I've really never been able to do that. So I think the real measure of the internal nasal valve, and valve is probably a bad term because it's not really a valve, is that this area of minimal cross-sectional area at the intake point of the nose should be thought of as the internal valve. And it's more than just this angle up here. It actually involves the lateral sidewall on the turbinate itself, as well as the septum. So if the septum's deviated high up here into this area, we would call that a valve problem. If the turbinate is enlarged in addition to this, and this is narrow, we'd want to address all these things to optimize the nasal airway through that valve area. Simply addressing this without at least looking at the others to see if they need to be addressed would be a mistake. The classic description for improving the nasal valve would be addressing that angle. So in this picture taken from one of the textbooks, this angle is improved by making incisions up in here and expanding this airway by placing grafts of cartilage taken from a portion of the septum that we don't need for support, for example, or from the ear, and expanding this angle such that we have less narrowing up here. As I mentioned, usually this is done in combination with other things. In very rare cases is it done by itself. This is one of those rare cases. This is a patient who'd come to me after having had an aesthetic rhinoplasty in the 1970s and was very happy with her nasal appearance but just couldn't breathe. And on exam, the turbinates were fine, the septum was fine, but this angle was narrow. It's one of those rare cases where it was really an isolated thing. And you know, by trying to preserve her nasal airway, but really expanding this area by about 1 millimeter on each side, this is the mid-vault area underneath with those spreader grafts, she actually got a tremendous amount of relief. Again, the radius to the 4th power, very small changes in the nasal radius of that tube can make a big difference in the nasal airway. And if you thought the external valve was hard to grasp, I think the if the internal was hard to grasp, the external may be a little bit more so. This external valve is probably even a poorer term, as it really should be called lateral wall support problems. And this lateral wall support of the nose is influenced by the connections to this piriform aperture bone out here, this upper lateral cartilage area, this lower lateral cartilage we call it, and this fibrofatty tissue. Weakness in any of these areas can cause the nose to collapse on inhalation through here. And that's what's called external valve collapse. When examining patients, this is actually not a patient, a fellow who, one of my trainees who agreed to do some photos for me for a textbook. One of the ways you can test this is by placing one's fingers on the sides of the nose, on the cheek, and seeing if that improves the nasal breathing when you inhale. It stops the collapse from occurring. Now, I think if anybody put their fingers and spread their cheeks apart, they'd probably be able to breathe better, so that's not such a great test. But simply placing your fingers there in neutral position and stopping the collapse is one way to do it. Another way is to support the inside of the nose, the lateral walls, with a Q-tip and seeing if that improves the nasal airway. But rather than call this external valve collapse, and you may hear, I may slip up and use that term because it's really the more common term, I think of it as lateral wall collapse, and I think of two different zones where this can be occurring. The upper zone is called zone 1, and these are really two classes of patients in my experience. And patients with zone 2 collapse, it occurs a little bit lower, more along the alar rim and the nostril, and there's a different set of patients and different set of treatments that we perhaps would use for those folks. This is an endoscopic intranasal view of zone 1 collapse. So this is the septum here. This is the lateral nasal wall. This is that pink mucosa. And you can see, I'm going to play that again here. When the patient breathes in, this whole sidewall just falls right in and hits the septum. And we actually have a grading system for this. We would call this a grade 3 collapse, going all the way to the septum and closing off the nasal airway completely. Often, patients with lateral wall collapse in zone 1 will get benefit from breathe right strips. And so what these are, if you don't know, is they actually have a piece of metal or something in them that helps expand and support that nasal airway so that it doesn't fall in with negative inspiratory force. They can be uncomfortable to wear all the time, and some people don't want to wear them all the time. So the answer for some folks who have this chronic problem may be a surgical procedure. What about collapse in zone 2? This is a video of a zone 2 collapse. You can see this is a little bit different. It's lower. It's right on that ala. You can see that margin of what we call the ala here, and it's just falling in. I'm going to play that again. And in this case, it was a result of prior surgery with the cartilage being removed such that this nasal airway was compromised. Why is this collapse occurring? A little more physics. What's happening here is we have an inherent weakness of that sidewall. And when we inhale, there's a negative force that's generated. And if that sidewall cannot compete against that force and negate it, it will start to fall in. And as we get a decrease in area, and we may also have a septal deviation or something in the inside, which is also making the area, that valve area narrower. We get a pressure drop and decreased pressure, and negative pressure generated, and it sort of becomes a vicious cycle and this whole thing collapses. So the treatment strategy here is to increase the area intranasally if possible, and also to resist that negative pressure in some way, shape, or form. Two primary strategies are used to try to do that. And one is to add cartilage to that lateral nasal wall to try to stiffen it as much as possible. And that is probably the classic technique. And this is shown here in this diagram from one of the textbooks out there. And the advantages of this technique are ostensibly that it adds structure. I would submit that, at least the way it's shown here, this wouldn't do much other than add bulk to an area that's going to continue to collapse. And in my experience, with rare exceptions, it was not as effective as I would have liked. Other disadvantages are is it adds bulk, and so there's a bit more of a cosmetic deformity in patients who have this done. It has its place, though, but there's another technique which I find more effective. And this technique involves placement of a suture to stiffen this lateral nasal wall, especially up here in the zone 1 area. And it's placed out to the bone and drilled into a small 2-millimeter hole in the bone and permanently stays there and helps stiffen that area and resist that negative inspiratory force. And this is something that we've written about. We've initially described it. It was actually initially described back in the mid-90s, but our approach to it was described in 2006 or 7. And we've done hundreds of patients with this technique. This is our bone anchor. I have no interest in the company. This is just to show you how small this is. This is about 2 or 3 millimeters across, and these are threads or sutures which are present, and we suture those to the cartilage and help stiffen that lateral nasal wall. Just a few comments on functional rhinoplasty. The nasal airway, first and foremost, should be evaluated and treated medically. And I mentioned that earlier. We don't necessarily want to take people under the knife and do surgery. And in many cases, treating the mucosa appropriately can result in very nice improvements in the nasal airway. But in cases when there are structural problems with the nose, a functional rhinoplasty may be indicated. And in this case, the goal is restoration of nasal structural support. Nasal breathing is a subjective measure. There have been many studies to try to measure the amount of airflow, and they found that they actually correlate very poorly with what patients say they feel in terms of their ability to breathe through their nose. So quality of life measures are actually probably better ways to measure outcomes in nasal surgery for the airway. And we actually did a nice analysis of functional rhinoplasty using a disease-specific quality of life instrument, and found that there were significant improvements in quality of life for our patients. This is a very busy slide, but we don't need to worry about the numbers so much, but looking at a number of different parameters such as nasal congestion, obstruction, ability to get air during exertion, virtually all of these procedures showed significant improvements in quality of life for our patients, which is a nice thing to know moving forward, especially in an age of evidence-based medicine. So we've talked a bit about functional maneuvers for the nose. I think now we're going to sort of switch gears and talk a little bit about aesthetic rhinoplasty. And, nose reshaping is about form and function. So all of the things I've talked to you about have to be taken into consideration even when you're doing a rhinoplasty just for looks. You have to think about what you're doing to someone's nasal airway, because you don't want your patient to be that person 20 years later who's asking someone to fix their nose because they can't breathe. So this is something we think about whenever we do surgery on the nose, even if it's just for looks. Thinking about rhinoplasty begs the question, what is the ideal nasal form? And these are just some images. Actually, some of these images are taken from emails to me from patients considering nasal surgery, saying they want their nose to look like this or that. Obviously, there's the ancient Egyptian ideal of the nasal form. People have actually tried to quantify what the ideal nasal form should be. This is actually a textbook which is by a couple of people who were at Stanford back in the late 70s, early 80s. And there are a few things that can be maybe taken from this. The idea that the nasal dorsum or bridge should form a nice, gentle, curving line from the medial brow out to the nasal tip. Okay? The idea that the rotation of the nose, that's this angle here between the lip and the nose, and the amount of upturnedness, so to speak, of the nose, should have an angle of about 95 to 115 degrees in women for the ideal feminine nose, and 90 to 95 degrees in men, so it should be more acute. Now, by the way, this varies inversely with height, so if you're taller, it should be less upturned. If you're shorter, it should be more upturned. Think about it in the sense that you wouldn't want to be looking up somebody's nose if they're very tall. And if they're shorter, they can get away with having their nose upturned a little bit more. So these are some of the ideals that are out there. That chin position affects the perceived size of the nose. The concavity or convexity of the facial shape can be affected by the nasal shape and the projection of the chin out here. So often in patients who have a, quote, large nose, who want it to be smaller, if their chin is small, one of the things we evaluate them for is potentially augmenting the chin at the same time as reducing their nose. But really the take-home message from all of this in my practice is that there is no ideal nasal form. The numbers which I showed you before were by and large taken into consideration for the Caucasian female when they were calculated. But not everybody is a Caucasian female. The ideal nose will vary with ethnicity, with gender, with facial shape, with skin thickness, which can alter the shape of the nose and the face, and personal preference. So the bottom line for me is that there is no cookie-cutter rhinoplasty. And what looks good on one person may not look good on another. So everyone has to be evaluated individually. When evaluating a patient, of course you want to look at their overall health. We're talking about here now an elective procedure. So if somebody isn't healthy enough to undergo a surgical procedure, they really shouldn't be considering having something elective. How is the nasal airway? We just spent a lot of time talking about the function of the nose, and we want to preserve that. We certainly don't want to impinge on that in any way. Has there been prior surgery on the nose? Revision rhinoplasty is a much more complicated topic, and we'll touch on it a little bit later. And most importantly, what does the patient expect from the surgery? And what can I communicate with the patient about what they might expect physically from the surgery? What do they expect from it? And more importantly, what are they looking for emotionally from this? Is this something that they're expecting will change their life, save their job, or save their relationship? Because it's not going to do any of those things. It can have a profound effect emotionally on some folks, but it's not going to do any of those things that I just mentioned. I think that in evaluating and understanding what can happen physically for patients, computer imaging has really changed the game for me in my practice. And I think that this kind of demonstrates nicely. For me, the computer simulation part of the consultation is very important because it's actually an educational opportunity for me and for my patients. For me, it's an opportunity to kind of understand what it is that they're looking for and understand if it's something that I can achieve. And for them, it's an opportunity to see what things might look like and for me to educate them on what is possible. Certainly, I can do anything with the computer imaging program, but I try to keep it as realistic as possible so they understand what they might be getting themselves into and what things might look like. And this is just an example of a patient who wanted the bump to be taken down a bit and the tip to be turned up in a natural way. Didn't want to look like she'd had a nose job or a rhinoplasty. And this is what we talked about in our computer simulations. And this is actually a very early result, just a few weeks after surgery. It's still a little swelling in there, but showing that even that soon after surgery, we have achieved something very close to what we talked about with our computer simulations. Just a quick word about the procedure. It's an outpatient procedure. It takes about 1.5 to 3 hours. There's a wide range there because of the complexity that may be different depending on the patient. It can take 3 or more hours in very complex cases or in revision rhinoplasty cases, which we'll talk about in just a little bit. This can be done under local anesthesia with sedation, but I recommend against that in virtually all cases. And I recommend a light general anesthetic, and we can talk about that more later if any of you have questions about that. After rhinoplasty, the nose is taped for 1 week. There's a piece of plastic, a so-called cast on there. Bruising can occur, depends on the patient. It can last 7 to 10 days. Generally, patients are very presentable after the 7 to 10 day time period, but final results can take a year. And why is that? I talked about this tent concept before, and again, the appearance of the nose is the result of a complex relationship between the skin envelope and the structural bony cartilaginous skeleton underneath. Very small changes in the interaction between these two can have profound effects on the shadowing of the nose and the way it looks. And this is not something that generally is noticeable to the casual observer, but it will be noticeable to the patient and to the physician, people who know what's going on. So a very small amount of swelling can exist and persist for up to a year, or even maybe a little bit more after surgery. And that's why in rhinoplasty we say final results take a year before they're really apparent. Now, aesthetic rhinoplasty is something that we have 5 or 7 day conferences on. So in the short period of time, we'll just talk about a few of the issues which I think are most commonly asked about in my practice. One is the dorsal hump, or the bump on the nose, and that's one of the most common reasons why folks will come in for a straight cosmetic rhinoplasty. And it seems like it ought to be a pretty simple thing to do, right? You just go in there and shave a little something off and you send them on their way. It's actually a little bit more complicated than that. And if you think about the structure underneath, so this is the same patient I showed you earlier, there's this outline of this bony cartilaginous septum here, which is in large part causing this bump. So these nasal bones and the septum are over-projecting a little bit. And we actually, with a rhinoplasty, can go in and bring that down by a few millimeters. And that's shown here by this red bar. So we brought this down by a few millimeters here. Again, it seems like it ought to be pretty simple to do. But when you do one thing, it affects more than just that one thing. And so when you take the top down, if you look at it from the front, you see that you actually create sort of what we call an open roof deformity of the nose, or basically a hole looking directly into the nose. And you can't just let somebody walk out of there with something like that because it'll look funny. And so we need to do something to close this. And what we need to do in that case is actually cut the bones on the sides in a precise fashion and move them inwards to close that. And this is why often people get a little bit black and blue after a rhinoplasty where the top is taken down. And these so-called osteotomies of the nose are one of the more complex things that we do in rhinoplasty surgery, and perhaps take some of the most experience. The reason is because we're actually not seeing what we're doing directly. We're doing it sort of by feel and by experience. And so we're using very small chisels to make these cuts. And it's a tough thing to learn, and it takes a bit of time, and it's something that we've written about extensively. So the simple takedown of the bump on the outside of the nose sounds pretty simple, but it's really a little bit more complicated than that. Then it becomes a question of how much do you want to do? As I mentioned earlier, there are some aesthetic norms that are out there that have been published about what the ideal nasal dorsum should look like. Well, unfortunately, not everyone necessarily adheres to that, and I think that's appropriate. Everyone has their own ideas about what they want their nose to look like. There may be some familial reasons or ethnic reasons why they don't want to bring it down as far as someone else, and we try to accommodate everybody. So this is an example of somebody who wanted a slight reduction of the dorsum. So we just brought it down a little bit. And as we go through these pictures, we're going to bring it down a little bit more. Another patient who wanted a little bit more taken down. She had a little bit more to start, and she wanted it to be a bit straighter. Somebody who wanted it to be essentially straight across or maybe slightly upturned coming down to the nasal tip. Again, there are no cookie cutter rhinoplasties. Another patient who we actually use computer simulations for all of these patients, but one here I'm showing again. This is what we planned, and this is what we ended up with. So we're turning up the nose a little bit more feminine, and all the way to where we actually turn up the nose probably about as much as I would do in somebody who has a very aesthetically pleasing appearance after bringing up the nose and bringing down the bump. So it's really about balance and personal preferences for some of the aesthetic maneuvers that we do. What about modification of the nasal tip? Nasal tip lectures can take up an entire day, so we'll just talk about a couple of things. Now, I've broken it down into three main issues that come up when folks talk about wanting to modify the tip of their nose. One is the rotation, and we mentioned this earlier. How far up or down the nose tip is upturned or downturned. The definition of the nasal tip. Often folks feel like they want it to be a little bit more refined looking, and also the size. So those are the three main issues. Now, how do you rotate the nasal tip up and down? Well, you do it by manipulating those nasal cartilages of the nasal tip, these lower cartilages. This is just, again, that diagram I showed earlier, looking at aesthetic ideals for nasal tip rotation. And I think computer imaging is a really nice way to demonstrate this to patients in consultation to determine sort of what rotation would look best for them. Now, this tripod that's drawn here is actually drawn there because we actually use that concept when we think about how far and how much to rotate that nasal tip up and down in the operating room. By shortening these upper limbs of this tripod, this tip will go up. By lengthening them and shortening this leg of that tripod for those cartilages, we can actually make the tip drop, which we need to do in some cases, which I'll show a little bit later. This is the patient I showed a little bit ago, just demonstrating this angle has been altered by using that tripod concept in addition to doing the things to the other parts of the nose. And again, there are no cookie cutter rhinoplasties. The amount of rotation that we perform depends on gender, height, ethnicity, patient preference, and a lot of other things. So we use computer simulations to determine what might look best. Definition is one of the other things that patients often come in talking about with the nasal tip. And the definition of the nasal tip is created by these so-called tip-defining points, and they're exaggerated in this model on the left-hand side of the screen. In fact, that would probably not be ideal to have that much light reflecting off of 2 points like that. But it's created by the highest point of these lower cartilages and the curvature of these lower cartilages. So by altering that with sutures, or by cutting them or doing other things, we can actually create a new nasal tip defining points for the patient. This is an example actually of somebody who had too much definition there and wanted it to be reduced. And this is what we call a bifid nasal tip, sort of like that idealized drawing which I just showed you. And she has very prominent cartilages which are separated by a cleft, and this is something that had bothered her for many years, since adolescence. And by simply going in, actually there's some asymmetry in this area as well down below. By simply going in and manipulating those cartilages using suture techniques, we can actually get them into a more symmetric and aesthetically pleasing conformation. Pretty subtle, but made a big difference for this patient. What about nasal size? The ideal nasal size will be affected by ethnicity and achieving balance and harmony for the face. If somebody has a round face, giving them a very thin nose can look very strange. Likewise, someone with a very thin nose who has a very thin face who has a very round nasal tip may look a little bit out of balance. So this is what we talk about, what we mean when we talk about balance and harmony in the nose. And this aesthetic dorsal line that was mentioned earlier probably is something to think about. I think it's a reasonable thing to consider in terms of an aesthetic outcome for a rhinoplasty. And on base view, there's this idealized triangle that we try to achieve. Again, I think this is somewhat ethnicity dependent and patient dependent. So this is somebody who had a rounded, or what we call a bulbous tip, who wanted, in addition to a few other things, to change the configuration of her nose such that this roundness, which is showing up here, and there's a piercing there, which is a little distracting, but the roundness of the nasal tip is sort of out of balance with the way this aesthetic line comes down. And if we draw the aesthetic line before surgery, we see that part of the reason it catches the eye subconsciously is it comes in narrow and then comes out again wide down here. And by creating a more balanced nasal tip such that this outturn here is a little bit less acute, we can actually achieve something which is a little bit more balanced for the patient and very natural appearing. Crooked nose is another popular topic, and patients after bar fights or other incidents of minding their own business and being punched, it can end up with broken noses. Sometimes crooked noses can be congenital. And it's usually due to a deformity of the bony cartilaginous skeleton of the nose. Often there can be an accompanying airway problem which needs to be addressed. And this is sort of demonstrated here. If this, imagine a cross-section through this gentleman's nose, you might see something like this where the bones have been crumpled in. It may be due to surgery, due to an osteotomy that was done and caused too much collapse of the nasal airway, causing an asymmetric appearing nose. In these cases, functional and aesthetic surgeries intersect. So you're doing something to fix the aesthetics of the nose in addition to improving the nasal airway. As I mentioned earlier, getting somebody to be 100% straight with a crooked nose is unlikely. Sometimes you hit a home run. Sometimes it's due to pure luck, because with rhinoplasty, things may not always heal exactly the way you intend them to because it takes such a long time. And there's a three-dimensional structure that needs to heal over time, and sometimes things might shift a little, and that's why crooked noses are one of the more difficult things to correct 100%. So to do this, we not only manipulate the bony cartilaginous skeleton of the nose, but we may use camouflaging techniques and grafts from other parts of the body to give the appearance of a straight external nose, even though the underneath skeleton may not be perfectly symmetric. And this is an example about as straight as one can get. After this, the nose is pointed off to the left before surgery, and afterwards is relatively straight after doing a manipulation of the bone and cartilage and using grafting techniques to get the nose straighter. Another example of somebody who had a traumatic nasal deformity that healed incorrectly with a bulge out here, and then after doing osteotomies and in addition to that a little bit of tip work to get the straighter appearance to the nose. What about the so-called ethnic nose? This is, again, another large topic. Typically, this refers to rhinoplasty on the Asian or African ethnicity nose. And there are a few commonalities to this. This is called the platyrhine nose, with thicker nasal skin, a lower nasal bridge, and a lack of cartilage support to the nose. Now, of course, we have to remember this doesn't apply to everybody, but in general, folks seeking this type of rhinoplasty require something to augment the nasal bridge and to augment that cartilage support of the nasal tip. The key, though, with this type of rhinoplasty, in my mind, is to create an ethnocentric, ethnic appropriate nose and not completely change the nose such that it does not look like it belongs on that face. So that's my philosophy with this type of surgery. And in this case, we were able to achieve that. This patient, we actually placed an implant which gives a shape to the nose, a nasal bridge augmentation primarily. And you can see here before and after on this 3/4 view, you've got now a bridge here. It's not overly high, not overly westernized. Here again on frontal view, you can see there's essentially no shadow across the top. And afterwards, we have a normal appearing shadow. And on side view, rather than have a lack of a nose leading up to the eye, we have a nasal bridge that comes up appropriately, but not overly high at that level. So this is a natural appearing ethnic rhinoplasty in my opinion. Lastly, we'll talk about revision rhinoplasty, and this is a large part of my referral practice. And why do we have such a large rhinoplasty revision rate? It's 10 to 20% nationally, and most of these are relatively minor revisions, a small bump here or there that needs to be modified. Some of them are major. Some require total nasal reconstruction. And this is something that really ought to be performed by folks who do a lot of rhinoplasty surgery. This is something that I think is best done by expert hands. One of the reasons is that all of the techniques in rhinoplasty may be necessary. And it's complex because of all the scarring in the nose. Often patients will have had multiple surgeries by the time they come to my office. And you have to understand that when you get in there, you may not find exactly what you expected. So you have to have the experience necessary to understand what a few different options may be once you get in there to repair things. You must be able to use different types of grafts. Often in revision rhinoplasty surgery, we'll use cartilage grafts from the rib, we'll use cartilage grafts from the ear, or other places to try to reconstruct the bony cartilaginous skeleton of the nose. They often will have functional problems, so the surgeon who approaches this needs to understand functional nasal surgery and restoration of the nasal airway in addition to nasal form. So our motto is reshape and restore in revision rhinoplasty. Patient had prior rhinoplasty and the tip was brought up a bit too high to an unnatural appearing position. This patient actually he was somewhat tall, and so we wanted to drop this down into a more appropriate position, and simply moving things a few millimeters can make a big difference in the conformation and the appearance of the nose. Sometimes too much is taken away. In this case, the nose had been over-resected, and so we have all sorts of problems here of lack of cartilage support of this entire nasal tip area. In this case, cartilage grafts were used to reconstruct the entire nasal tip. The alar cartilages, the dorsum here, pushed these down so that there wasn't so much nostril showing, and rebuild that entire nasal tip. And so this can be a very complicated surgery. In some cases, it's an issue of nasal airway function in addition to the ability to the appearance of the nose. This is a Polaroid that this patient was kind enough to provide me of himself before he had his first surgery back in 1991. And what he really wanted was for this tip to come up a little bit and this just to be a little bit straighter. 2 surgeries later, and this was the Polaroids around the mid to late 90s, and the tip has dropped and things are not looking exactly the way he'd planned. And this is the appearance of this kind gentleman when he came to see me, and he could not breathe through his nose. And now his bridge has also been built up. You can see that. Someone's gone in, and this is after 5 prior surgeries. And so his desire at this point was really to be able to breathe through the nose again. And he had external valve collapse, and we actually used bone-anchored sutures in addition to grafting techniques and removal of this graft, which was unnecessary and aesthetically gave him a bit of a Roman nose. 1 year later, here he is, a much more natural appearance, and actually it's what he had wished with his first rhinoplasty he'd achieved, and he's able to breathe through his nose, which is really what he wanted at this point. So it's really a very gratifying procedure. It's a complex procedure to perform, and something that really tests all of your surgical skills. So putting it all together, with rhinoplasty our desire is to reshape the nose both internally and externally, to restore the nose functionally and aesthetically, and put the nose in balance and harmony with the shape of the face, the ethnicity of the patient, and the psyche of the patient. So with this type of surgery, with very mild changes to the shape of the nose, we can make a profound impact on the overall appearance of the face and restore facial harmony. So rather than being one of the main features that we observe when we look at someone, it can sort of blend into the rest of the facial aesthetic. This is a patient who came to me and desired this during our computer consultation. So this is a simulation of how things were planned. She wished the bump to come down a little bit of tip modification to come up, and a natural appearance most importantly. And this is how she was about 1.5 years after surgery. So she's settled in and she's gotten pretty darn close to our plans and a very natural looking appearance. And we can look at all the different views here to show three-dimensionally how we've changed this tip a bit to fit in more balance with the face. And I'll just run through all these here. So I thank you for your attention. If you have any comments or questions, you can always email. If you have any questions about coming in or any referrals, the number's up there, and I'd be glad to field any questions you may have. Thank you very much for your attention. So the question is snoring and its relationship to nasal breathing and how much can be caused by other locations. And one thing you're referring to is obstructive sleep apnea. Patients who have difficulty sleeping due to obstruction of their airway when they sleep, they wake themselves up, it can have a significant impact on their physiology and their quality of life and their health, are sometimes simply snorers, or they actually have true obstruction. And the nasal airway and ability to breathe through the nose is often a cause of this, and I didn't really mention it, but fixing the nasal airway with a functional rhinoplasty is often something we do for patients with obstructive sleep apnea to see if we can actually improve their ability to sleep. Now, snoring is sometimes caused by the nasal obstruction, but it is often caused by the palate itself actually sort of flapping, if you will, against the posterior oropharynx. Sleep apnea can be addressed by addressing the nose, the palate, the base of the tongue, or elsewhere, ultimately even moving the jaw forward. And so there are a number of different areas, and evaluation for that by a sleep specialist is probably most appropriate. The question is, that was asked was about the bone-anchored suture technique, I believe, and whether that is a major surgery or not. Well, to be frank with you, if I had a hangnail removed, if it was me, I would consider that a major surgery. So it's really a personal issue whether a surgery is major or not. But I think what you mean is it considered in the lexicon of surgery a major surgery? And the answer is no. But the approach that we use is a traditional functional rhinoplasty approach. Now, that suture technique was originally described in the mid-90s by other authors through a minimal approach with a small incision by the eyelid and a small incision inside the nose, and actually was largely found to be ineffective. What our contribution to the literature was to use this technique with the entire nose and midface opened with a traditional rhinoplasty approach, and it's much more effective that way, largely because a suture by itself is not going to change things, but if you can reposition the tissues and let the suture support things while they heal in that new position, it will be much more effective. And I think that's why we found it to be quite effective. So the short answer to your question is yes, we use a rhinoplasty approach, and we don't use minimal incisions to do that. That's a great question. So the question is, can we create cartilage artificially so that we don't have to harvest it from elsewhere? And one of the disadvantages of using autologous tissue from your own body is we do have to go to another site, make another incision. There's always a potential risk of a problem there. Thankfully, that risk is very low. But the answer to your question is there is not yet a way to generate artificial cartilage, and there are people who are doing active research on this that I'm very familiar with, trying to generate that. But I think that's not even on the horizon yet. I think it's a little bit beyond that. There are a number of technical challenges involved. Cartilage is also being, people are trying to generate cartilage to restore joints, not just for rhinoplasty surgery. But there's a big impetus out there to develop that, but it's not quite there yet. The question is, what is the cost of the nose surgery? Well, it depends. Strictly aesthetic rhinoplasty with no functional problems like a septal deviation and so on is something that is essentially all out of pocket, and that'll depend on the surgeon's experience level. And it can range from probably about $5,000 to about $15,000. That's including, all the other fees. Now that'll vary geographically and with experience level of the surgeons. Now, in many cases, this is a functional surgery. If it's a purely functional surgery to improve breathing, then it's a different issue. The question is, would I be able to speak to chronic sinusitis and the conditions that would justify surgery? I have a background in otolaryngology, head and neck surgery, in addition to board certification in facial plastic surgery, and I limit my practice now primarily to facial plastic and reconstructive surgery. Having said that, I think I might be able to answer your question to a certain extent. The problem of sinusitis is a little different one than the one I've been describing. Now, patients with chronic sinusitis have chronic infections of the sinuses, which I didn't show you, but they're basically air pockets inside of your skull surrounding the nasal airway. And so often patients with chronic sinusitis may have a septal deviation or just so much swelling inside the nose, which are those variable structures we talked about, that they don't feel like they can breathe very well. But chronic sinusitis is treated differently. If somebody has chronic sinusitis that is not responsive to medical treatment, and the definition of a non-responder will vary a little bit, so I'm not going to go into that too much, then they may be a candidate for what we call endoscopic sinus surgery. And with this surgery, small scopes are placed into the nose and the sinuses are opened such that any problems with drainage are relieved. And so I think that the indications for sinus surgery are starting to shrink a little bit. It was perhaps maybe overused in the early 90s. But as we understand more about appropriate sinus function and treatment, we're getting a little bit better about honing in on patients who will be good responders to surgery. Well, the question is then about the sense of smell and its relationship. So the area where the nerves for olfaction or smell come into the nose are very high up in the nasal cavity near the base of the skull. And there are a few reasons why one might not be able to smell. One might not be able to smell simply because no air is getting up there, and so no particles, smell particles are getting up there, and you just don't sense it because of that. Or there may actually be damage to the mucosa, which holds the nerves, and that can be a reason why you don't have smell, which is also called anosmia. So it's sort of a complicated evaluation. That the question is, when you eat food, is there a pathway to the olfactory mucosa that doesn't go through the nose? Well, actually, it's sort of the reverse. You know, smell is a very important part of your taste function when you eat. So if you can't smell properly, even though your tongue taste buds are working, you may not be able to taste things properly. So the question is to make a comment about the gentleman whose nose had collapsed. But actually, I showed, I think, more than one. But are you referring to the one towards the end? No. With the multiple surgeries? And so one, you know, people can have multiple rhinoplasties. And through no fault of theirs or the surgeons, things may not turn out exactly the way they expected. Because it is, I would consider face transplants, notwithstanding the most complicated procedure we perform. If you really look at judging the results very critically, it's one of the most complicated procedures we perform in facial plastic surgery. So, and that's why there's a revision rate of, you know, up to 20% depending on who you ask. And so patients will come back with functional complaints or aesthetic complaints and need to have touch-up or major surgery to try to alleviate those issues. In that gentleman's case, he'd had a number of surgeries, and unfortunately they hadn't worked, and we were fortunate to be able to repair that with a variety of newer techniques. What can we do for folks who've had multiple surgeries and damage to their nose, and what sorts of materials do we use? Well, the answer to your question is we can restore the nose, but I would never say that we can restore it to the way it was exactly before they had surgery. But we hopefully can restore it to a functional and aesthetically normal appearance when we're done. And the materials that we would use would be, in my preference, autologous, in other words, from the patient themselves. There are artificial materials you can use. There are types of plastics or Gore-Tex or other things. And those are fine. They do have a slightly higher risk of infection, but they can be used as well. The question is, what is the definition of the mucosa, and in what ways can it be damaged? The mucosa is a term that can be used anywhere in the body, really, for a lining of epithelial lining on the inside. And so when we talk about the nose, we talk about the mucosa of the septum and the turbinates. The mucosa in the sinuses is a little bit different because it actually has cilia, little hair-like structures that beat and move mucus. This is the same type of lining you have in your lungs. And so in terms of damage, it can occur in any number of ways. It can occur due to surgery. It can occur due to external agents or exposure to something. So those are the main ways. Chronic infection can lead to scarring of the mucosa. So a number of different things can happen. Any other questions? I'll be glad to stick around afterwards if any of you have any sort of more private questions. So thank you very much.
Think Forward. Think Research Channel.